Treating multi-organ failure is really nothing new to us in the cardiac care unit. And yet, it's usually either a situation where the patient gets better or there's a natural endpoint, and that is cardiac arrest that's not resuscitatable. But if you take the left ventricle out of the picture, now all of a sudden that puts us into a whole new uncharted territory of being able to work with secondary organs that have failed to even lower depths than we've ever dealt with before. I have a clinical research grant with Aortic, otherwise nothing else to disclose. Just a brief outline, we're going to talk about the program structure that's necessary, patient selection, preoperative preparation, and then get into the ICU assessment and management. And then, if we have time, talk about a few of the potential complications that we can run into. First of all, I think to be successful in this field, we really must have a multidisciplinary team. And you've heard of this from our previous speakers, but I think here it's even more important because we have to have that patient evaluated on a day-to-day basis from multiple specialty areas. And it requires very detailed-oriented personnel. There just has to be comprehensive coverage of all aspects of the care. There's really nothing that can be left to wait for later. We have to be very preemptive in our approach to patient assessment. And I think it's important to have standardized order sets. And the reason for that is it will ensure the completeness of your management plan, but it also provides a consistent basis for which logical adjustments can be made. And there's less likelihood of errors being made. Here again, we have to remember that being late in this group of patients may actually be too late. And as with any case, any surgical case, a successful postoperative care starts with and depends on careful preoperative patient selection. And I think the one thing that is very difficult to get across to our cardiologists and our referring physicians is that VADs should be looked at as an alternative, not as an alternative to death, but as a bridge to life. And that's our biggest problem now, is getting patients too late. Waiting too long will give you a heavy price to pay in that intensive care unit care postoperatively. So let's talk about patient selection. First of all, we should start looking at patients when they move into that poor functional capacity area and where they have frequent decompensations. And patients that have life-threatening ventricular arrhythmias should be looked at very early. We don't want to wait for renal dysfunction. We don't want to wait until we have them on multiple pressors. And we don't want to wait for cardiac cachexia. We do want to cure any infections that we have before considering the implantation of a VAD. And ironically enough, we sometimes think that, well, if we have severe pulmonary hypertension, that's a bad sign, but maybe not. In fact, if the right ventricle can generate a good pressure, it may mean that that pump is actually okay. I worry more about the patient that has a very dilated RV and a low PA with a high CVP. That's the group of patients that will get us into trouble with right ventricular failure postoperatively. And again, surgery is best when it's done electively. If we're looking at a crisis situation, we probably should think about a bridge to decision with some sort of a short-term device rather than going through the full big operation of implanting an implantable device. Fortunately, with the INTERMAX registry, we do now have a way of monitoring these patients, watching to see just how patients will do at the varying degrees of illness. And if we look at that and compare the sickest group, what we call the crash and burn group of patients, with the more stable group of patients that just have poor functional capacity, then we can see that the survival to discharge will increase from about 68% all the way up to 96%. And in fact, the length of stay will be shorter. The sicker group of patients will end up on the average being in the hospital for 45 days, whereas if we go with that more functional group of patients, we can usually have them out of the hospital within about 2 weeks. And again, A shorter length of stay in the hospital obviously means a much shorter length of stay in the intensive care unit. What are the things that we can do when we see that patient preoperatively to try to get that patient ready for surgery? Well, we have found that if we put the patient on an intra-aortic balloon pump 24 hours preoperatively, it will reduce the incidence of the need for right ventricular assist. And echoes are confusing. In fact, I think from trying to predict who's going to do well and who isn't, it's almost impossible to believe the echo. You know, the right ventricles all look bad by echo. And really what's more important is the hemodynamics. So again, that helps to get that patient in the coronary care unit with the CVP in on an intra-aortic balloon pump, and that allows us to then begin to fine-tune that patient a little bit more and get him ready for surgery. We want to get that CVP below 20, if at all possible, and we'd like to see the CVP lower than the capillary wedge pressure. And it may be that we even need to start some of the anti-pulmonary hypertensive agents, whether it's naseritide, milrinone, aprostadil, or one of the others that we've heard about earlier. What is our ideal? Or what, maybe I should say, what is the minimum that we would like to expect going into surgery? Well, we'd like to see that creatinine below 1.2. We'd like to see the INR brought down to 1.2. I'm sorry, the creatinine down to 2.5. We'd like to see that INR brought down to 1.2, hemoglobin up over 10. Try to get that platelet count at least in the range of 150,000. The higher the albumin and the pre-albumin, the better we are in the postoperative period. And of course, we know hepatic failure is a problem. If that total bilirubin is greater than 2.5 or the enzymes more than 2 times normal, we're going to struggle a little bit postoperatively. And again, it'd be nice to go to the operating room with the right atrial pressure less than 15 to 20 and try to even get the pulmonary capillary wedge pressure down to less than 24, 25 as well. We do stop the Coumadin about 3 days preoperatively. We will bridge with heparin and stop that on the way to the OR. It's important to rule out HIT. It's a very common problem in some of these patients. They've been in and out of the intensive care units on and off heparin drips, and they get sensitized again and again and again preoperatively, and there's a high likelihood of some of these patients having HIT. That will be a disaster postoperatively. We assess the platelet function, and then we will use vitamin K or fresh version plasma to correct the coags if necessary. We try to stop the ACE inhibitors and the beta blockers before we go to the OR. And we'll turn the AICD off on the way to the OR and set the pacemaker in a VOO position. However, in the postoperative period, after we are certain that the patient is free of bleeding and it looks like we aren't going to go back to the OR for RV failure to put an RVAD in, we then turn the device back on. Now, the question always comes up, should these patients all have devices? No, I don't think so. But if the device is in place, why not use it postoperatively? So we will turn it on post-op. Now, the question of antibiotic coverage. There's certainly evidence that the rematch protocol, which was a 4-drug prophylactic program, we know that that worked well. However, it looks like we probably don't have to go to that extent, particularly in patients that are more ambulatory and can be brought in on a more elective basis. Many of our centers now are going to using pretty much the routine cardiac prophylactic antibiotics in the preoperative period. Now, from a monitoring standpoint, you know, we have arterial blood pressure and from the arterial pressure line, we always have a CVP. But if you can, ask your cardiologist or your anesthesiologist to put in a continuous O2 monitoring Swan-Ganz catheter. You know, the VAD parameters that we have, other than the micromed pump, which does have a flow probe on it, all the rest of the VADs have calculated cardiac outputs. So it's nice to have that continuous O2 monitor on the Swan to compare your cardiac output that the VADS says you're getting and with what your Swan is telling you. And then, of course, you also have the continuous venous O2 saturation to help you out as well. Okay, so let's now move to the ICU. We've got the patient who's coming out of the intensive care unit. What are we worried about? Well, pretty much like any other case from that standpoint. Initially, we worry about an adequate blood pressure. We have to have adequate LVAD flows, and again, it's a question is whether you trust those on the monitor or whether you have your SWAN to help you out. There's always that question of how much bleeding is going on. Got to watch that temperature. Cold patients will bleed more. Blood gases, of course, are important, urine output. And then the Achilles heel to this operation with left ventricular assist devices is right ventricular function. And that's going to haunt you from the moment the patient arrives until the moment the patient goes out of the ICU. And then, of course, we also would like to know, if you're not the surgeon that was in the operating room, you'd like to know what went on in the operating room, because sometimes some unforeseen things have happened, or there have been problems that have been faced in the operating room that will have an impact on your postoperative care. So we want to be brought up to date on all of those details as well. The big three, as far as problems that you'll face, obviously coagulopathy with bleeding, and then vasodilatation and hypotension, and right ventricular failure. Well, let's talk about the hemodynamic aspects, the hematological aspects first. First of all, postoperative bleeding in this group of patients is very common. In fact, clearly 25% of your patients are going to go back to the operating room to have a washout or to try to correct a bleeding problem. And for that reason, some centers are more likely to pack wounds open, and there's nothing wrong with doing that. It is a concern for an increased incidence of infection, although ironically, when people have looked at their infection rate in the patients that have been left open for 24 to 48 hours as opposed to closed, there's a pretty low incidence of infection as far as the likelihood of developing it in one group as opposed to the other. And of course, we want to use blood, we want to transfuse with the blood products that are needed, but that's always a two-edged sword. We know that blood transfusions will cause RV failure, pulmonary insufficiency, activates the inflammatory cascade. We get transfusion reactions. In the bridge to transplant patient, we worry about sensitization. So we need to get on top of it in a hurry. We want to be aggressive about correcting it. But on the other hand, we need to be specific about what we're giving. And that's where probably things like TEG, the thromboelastography, are important. And we do make use of that, and I think many centers are. And again, you always want to keep in the back of your mind, has this patient developed HIT with any sign of continued platelet deterioration? What are the goals that we shoot for? We'd like to get here just as fast as we can. We'd like to get that INR down to 1.5 to 2, the PTT less than 45 seconds, hematocrit greater than 24, platelets up over at least 65,000, and a fibrinogen over 200. Now, if you haven't gotten your coagulation parameters to this level and you're doing some bleeding, then you're probably justified in pushing that patient a little bit harder with products before going back, providing the patient is hemodynamically stable. But once you get your coags stable and in this goal range that you're shooting for, then if you're having ongoing bleeding, you probably just should go back to the OR and wash out and make sure there's not something else that can be taken care of. Well, let's switch to the hemodynamics. The trick here is balancing left ventricular assist device flow with the demand that's placed on the non-assisted RVAD. And of course it's obvious, but it really hits you when you're taking care of this patient that an LVAD is great, but it only helps the left side of the heart. Years ago we used to think that over half of the patients really should have biventricular support. In fact, that's the reason we started this business with trying to build total artificial hearts rather than left ventricular assist devices. We know that there's really only probably 5% of the patients now that will require an RVAD, but that doesn't mean that we don't struggle with right heart failure day in and day out. And inotropes and vasopressors are instruments that we use. We try to optimize the ventricular performance, but also optimize our systemic vascular resistance. And you've seen and heard about a whole bunch of drugs today that can be used. The pattern that we've used at this point now at the Mayo Clinic When we come off pump, everybody's on 0.25 to 0.5 of milrinone. Everybody gets started on 0.02 mics per kilo of epinephrine, and then we add vasopressin if need be. Isoprel can also be a very good drug for the right ventricle. And there's other combinations. These all work, and it's just a matter of getting a protocol worked out, something that seems to work for you, and then start with that and go from there. Well, if we have acute hemodynamic deterioration, what can be the cause? Obviously, right ventricular failure can be the cause, and if you have a low cardiac output but a very high CVP, and you get your echo and you see that big distended right ventricle with TR, that's probably what you're dealing with. But it can be pericardial or pleural tamponade, just as in any other case. But another problem that we face in this group of patients all too frequently, and something that's very difficult to treat sometimes, is that systemic vasodilatation. May well be secondary to the systemic inflammatory response that we have in these patients. It seems like it's worse in patients with severe hepatic failure that we deal with, but it may be adrenal insufficiency too. We don't want to forget that, and it may be that we need to give some steroids in this picture. We don't think about that often because you're always worried about, well, steroids may lead to infection, so we don't want to do that, but it's worth checking. Or it may be LVAD dysfunction. Now, it's rare these days that we see mechanical failure of the pumps postoperatively, but we can have inadequate LV filling, and more often this is a result of RV failure. But we can have malalignment of the uptake cannula, and that can give us problems. Or we can have some obstruction of the outflow cannula. Now, one thing to remember with these axial flow pumps and centrifugal flow pumps, if we have a kinked inflow or a kinked outflow graft, the power on the pump will go down. So if you have a lower cardiac output and a drop in power and hypotension, then think about position of that cannula or the lie of your outflow graft as you close that chest. It could be that that's your problem. Well, once again, if the right ventricle is happy, the rest of the body is happy. There's dependence of that LVAD function on the RVAD function, and every other organ faces the same thing, whether it's the renal, hepatic, cerebral, or the GI system. If we have a high CVP relative to a low systemic arterial pressure, it means problems, and that means right heart failure. And of course, we know all too well that a congested liver doesn't do a very good job helping us put out the proteins we need for the coagulation in the post-op period. Well, let's think about what we do now when we start up this left ventricular assist device. First of all, we see an acute drop in the left ventricular pressure because we're unloading the left ventricle. And then there's a simultaneous increase in return to the right side of the heart. We've got more forward flow on the left side. So this provokes some immediate alterations in the geometry of the heart and the valvular function. First of all, and I'll show you pictures of this in a minute, we see the septum pulled to the left. Then we see the right ventricular free wall get distended, and the shape of that RV turns from a moon-shaped or a crescent-shaped to a spherical structure. And what does that do? That pulls on the papillary muscles, and then we get severe TR. Now, it helps the MR, obviously, but we're not worried about that when we have an LVAD in place. So here's what we have with normal anatomy, normal right ventricular geometry. And then if we turn the flow on the pump up too quickly, we'll begin to suck that septum over to the left. Now, this creates a couple of problems. I'll talk in a minute about suck down, and if we pull on the heart too quickly, we'll swing that septum all the way over to the point that it occludes that inflow tip. But look at that right ventricle. It becomes very spherical, and it's easy to see how we will now get wide open TR, and we just accentuate the problems for an already weak right ventricle. Well, quickly we'll go through some of the other things that we need to take care of. Nothing different than other procedures in this case: glucose control is very important. We started in the OR, continue it into the ICU, use an insulin infusion. We want to keep that glucose between 80 and 110, and we know the improvement that we get in any cardiac case by managing that. Let's don't forget about nutrition. These people are all malnourished when they come in. And it's all too tempting to say, well, maybe by tomorrow he'll be able to get extubated and eat, and well, okay, let's give it one more day, and then one more day, and lo and behold, now we're out a week, and we really haven't given any nourishment to the patient. If it's a patient that can be nourished early, enterally, that's what we need to do. Use the small bowel. But if oral intake is compromised because of just the early satiety or dysphagia, or if they're still on the ventilator, don't wait for them to be able to eat. Put a feeding tube down and get some nutrition going into that gut. Sometimes, though, the gut does not work, and then we have to go to parenteral nutrition. And here again, this is where I think another one of our subspecialties, we really should look to our nutritionists to help us define the patient-specific nutritional needs and remedies that we can put in place to get our patients off to a fast start. Other things, obviously, we worry about thrombophlebitis. We want to get the compression boots in place, need to get a proton pump inhibitor started, keep track of gastric drainage, put that patient in a little bit of a reverse Trendelenburg position. We want to remember and not forget also the physical therapy that's needed. Rehabilitation. Here again, many of these patients have basically been on the couch or in bed for months, and now we're expecting to put a pump in and get them up and walking as quickly as possible. We need to start this in the ICU, and that's just another member of our team that we have on board immediately working with the patient. The other thing that is unique about ventricular assist devices is the fact that this patient and his caregiver are going to be responsible for everything that has to be done for the patient when he goes home. Now, that's one thing to know how to help the patient get in and out of bed and do that sort of thing, but now we have a drive line that has to have the dressing changed every day, and we've got a pump that has all sorts of peculiar alarm systems and management problems that has to be learned. And we actually require the patients and their caregiver to take an exam before they go home, and if they don't pass the exam, the patient stays in the hospital until they can pass that exam. And ironically enough, this sometimes is the factor that is responsible for lengthening the length of hospital stay, because we'll have the patient ready to go clinically, but the family or the patient still haven't quite gotten it. So we've got to work on them another day or two before we can let them out. So again, this is something that can be started in the intensive care unit. In fact, when it comes to infection of the drive line, we've found that it's probably best to get the caregiver taking care of that drive line immediately in the postoperative period, because that's the one that's going to be doing it. Those are the bugs that we're going to be dealing with. It's not going to be whoever the nurse was that comes in each day that changes that milieu. Then we have the setup immediately in place that will be the situation at home. Let's talk about anticoagulation. The big thing to remember here is that all pumps are not the same. And this has gotten far too many of us into trouble, where we've used one pump and gotten pretty comfortable with the anticoagulation that's needed for that pump, and then a new one comes on the scene, and we get into the study, we decide that, gee, we know how to anticoagulate a patient, and suddenly find out that we've got a pump thrombosis or a bleeding problem that we never really had to worry about too much in the previous one. It's because pumps are different. So follow the manufacturer's guidelines and try to start with that, and then you can modify it as you gain experience from time to time. The whole question now in the field is whether we need to start heparin in the ICU for once the chest tube drainage goes down. And most of us now are recognizing that we probably can just go straight to Coumadin and not use immediate heparin in that first 24 to 48 hours, unless the patient is going to have prolonged needs for intensive care and inability to use the gut, then we probably should start heparin. But if it's a patient that you can get extubated the next day and start eating and drinking the next day, we probably can go straight to Coumadin and platelet inhibition and not use heparin as a bridge. What are we going to do if we have pump thrombosis? Well, first of all, when you see signs of thrombosis, obviously the first line of action will be to increase the level of anticoagulation and hope that there will be lysis of the thrombus and we'll manage to get out of trouble. But if the pump does show no signs of improvement, then we've basically got two choices. One is to change the pump out, and maybe that is the safest thing to do. It's hard to do because it's sort of psychologically tough. It's another big operation to go through. We sort of feel like we've failed if we've got to change the pump out, and it's a struggle to put ourselves up to changing it out. And it's tempting to go to thrombolytics. Now, thrombolytics do have their place, and I think if you catch the early signs of thrombus in the pump and everything else is stable and the patient is not a high risk for bleeding problems, then perhaps a TPA protocol is worthwhile. I think that there's been a little addition that many centers have used now that I think has been very helpful. You know, it used to be we felt that we wouldn't dare put a catheter into the left ventricle because what would happen if that catheter got sucked into the inflow cannula and jammed into the impeller? It'd all be over immediately. But our interventionalists now are recognizing that they can carefully put a catheter right in the left ventricular cavity and start infusing TPA at 1 milligram a minute. And as long as we limit ourselves to a maximum dose, and usually about 40 to 45 milligrams is the most that we should use, but give it only until we see the pump power change. Once that pump power drops, then stop and get on with your regular anticoagulation. So it is a protocol that can be used, but it should always be used with caution. As far as infection, again, systemic antibiotic prophylaxis should be used, probably only for 48 hours, and then after that we should go with directed treatment as needed. There's a percutaneous driveline that will always be a site for potential infection, and the best thing to do is to get that sealed quickly, and that involves immobilization immediately when you leave the operating room and then meticulous wound care thereafter. We need to use aseptic handling of monitoring and access lines as usual, and of course get those lines and those catheters out as quickly as possible, and then just use the strict adherence to the basic principles of infection prevention. Patients can bathe and shower, but we shouldn't let them do that before the percutaneous lead is sealed with good tissue ingrowth. There's all the other factors that help us ward off infection. We want to have good nutrition, keep the diabetes under control, avoid any immunosuppressants that we can. This will all help us avoid any major problems with infection. And with the second and third generation pumps, fortunately, infection has not been a huge problem. Just a brief note about the care of the exit site. I mentioned that it's helpful to get the family member or whoever the caretaker is going to be to get involved immediately and then turn that job over to them during the rest of the hospital stay. And some sort of stabilization needs to be used. There's a stabilization belt shown here called the Delia belt that many of us will use. But you can use a Hollister band, you can use anything you want as long as you stabilize that. And if you do it quickly, hopefully this is what the driveline site is going to look like. Now it doesn't mean that a break in the skin seal is necessarily a disaster. Here's obviously one that has broken down several times, but it's less of a barrier now. You know, you get that granulation tissue there and then that scar's over and now you're okay for a while. But this driveline is more susceptible to infection than the one you saw in the previous picture. What other complications can we run into? Well, there's a lot of them. Here's a picture of a guy that's gone out and been very active, and it scares me when I look at that broken leg off that ladder underneath the animal. I wonder who was on that ladder when it broke, but I bet it was him. But, there's a lot of problems we can run into. Pump thrombosis is one of them. The rate of thrombosis runs anywhere from the rate of 1 to 4%, perhaps up to as high as 8 to 10% with some of the pumps if we don't watch our anticoagulation well. We have to always worry about flow path obstruction and whether the pump will stop or not. I talked about the suction events if we have our pump set too high. GI bleeding in axial flow pumps can be a problem. Here's a thrombus in this stator, and it may not cause problems with cardiac output, but it can cause hemolysis, and that may lead to the need of changing the pump out. GI bleeding occurs in 20 to 40% of our patients with axial flow pumps, and more often than not, it's from AVMs, or as our gastroenterologist correct me and say angiodysplasia, because maybe it isn't congenital. Well, we could talk for a whole day on that issue, but in concluding, I would just say that it's an exciting new field that will challenge even the best of the intensivists, but one that will bring rewards far beyond anything that we've experienced yet in the field of medicine. Mechanical circulatory support is a reasonable option for the treatment of congestive heart failure who have failed medical treatment. The appropriate patient selection is crucial. And the management requires multidisciplinary approaches, and with all that, the quality of life can be markedly improved, and survival results certainly have been encouraging. Thank you.
All right. That's going to take us right up to the break. We've got a long day ahead of us. I'm hopeful that the speakers will avail themselves for questioning at the break if that's desired.